So my name is Sabrina Jackson, and I am the Director of the Partnership for Diabetes Health Equity at Morehouse School of Medicine. I've had the privilege to mentor about 6 teams from across the country through a national learning collaborative around what we call 3-element model care. And so we took the idea of, can we take 3 entities and bring them together and help them to build a diabetes care system that will decrease disparities. So we wanted it to be a clinical entity, a community organization, as well as someone who owns some big level data. And could the 3 of them come together and begin to work together to look at what the problems really are, the things that we know that will drive disparities, and then work together to come up with solutions to help eliminate them.
And when we call this thing a learning collaborative, we truly want to emphasize that to make a difference, you have to be listening and seeing what's happening on the ground. You can't just be rolling out a program because you think it's good and invest a lot of time and money in rolling it out, and then find out it doesn't work for the community that you're trying to serve. So we really emphasize testing, trying it out, and learning from that testing, learning from each other, and finding out what makes a real difference.
We brought together over 15 different organizations from 15 different communities who didn't know each other. Bring those collaborative teams together as one to share best practices.
Are we able to share data one to another? If the community is collecting a certain kind of data, maybe me as a clinician, I might need to see that data. And in the same way, these community partners may need to know what's really going on in the clinic so that we can work together more meaningfully to move the needle on these healthcare disparities.
But chronic health conditions develop out of inequities within many of our systems. So where people live, where people shop, many times they don't have the same resources in that community from one zip code to another. So when people live in those communities, they are at higher risk of developing chronic health conditions. And they actually have less access to the medical providers, healthcare providers, but also social service providers or behavioral health providers, which they really need access to and to have that support in order to make decisions on a daily basis that allows them to live well with a chronic health condition.
What we feel like the solution is for each team and for every community to have a 3-element model of care. That patients can no longer just go to the clinic and have siloed care. The care has to leave the clinic and extend to the community where the social determinants are, things that really affect the care of patients. And so clinical entities have to now begin to think about housing, and they have to think about safety and education and literacy level. But many people don't really know how to do that. The traditional model of care in America is siloed. We have the healthcare arena that involves clinical entities, and then we have the public health arena that involves people and coalitions, and they speak the language of neighborhoods. And we've got to learn how to come together to teach us how to allow the patient to tell us what they need and what their real problems are. And then you also have to identify meaningful data. We can't just say we did a good job. We don't know what the patient thought about that. So how do we take clinicians and teach them how to speak the language of the community, but also to meaningfully collect and analyze data to increase equity and decrease disparities? Today, this meeting has really been good. What we wanted to get was a first-hand experience of those participants. We wanted to know what they thought about the kind of technical support we provided them, with the guidance that we gave them in terms of the charter, the kind of measures they should be collecting, what should they be doing in their day-to-day. And then we also provided training for them around quality improvement methodology. And so what we saw today was the experience that each of them had. We wanted to see, based on what they thought, how well it went. I think that one of the key things that we have faced as clinicians and those who serve the underserved is that oftentimes we're under-resourced. We have these big goals, we have patients that we really care about, but we're not as effective as we'd like to be. And much of that is a lack of resources. And so we feel like this collaborative has shown us that teams really do need support. They need support in terms of training that's readily available. but they also need this community that we've built where they can be connected with other people who are doing what they're doing to give them that kind of support, but also boots on the ground, real world examples of what has worked in their community. I think we'd also like to, do some publications and put out these findings to look for more funding, because these kinds of initiatives need to be duplicated all over. We're one project, PDHE at Morehouse School of Medicine, but can there be other programs that are designed to support a healthcare collaborative? This model has worked really well in the education system, but can we do this really on a large scale in the healthcare community so that providers are taught what they need to be able to effectively collaborate so that the level of care is raised for these patients?